Good evening, everyone. My name is Paula. I'm part of the Brain for Care Team USA. We are a Brazilian startup that has recently entered the US market due to the FDA clearance. First of all, I would like to thank you everyone, and especially Manoli Education for providing us with this space. Tonight, we'll talk a little bit about Icp Waveform in hydrocephalus. And to help me with this, we have three fantastic neurosurgeons. I'm Dr. Nelci, Care Team USA. Dr. Nelci, that has Dr. Giselle, and Dr. Raphael Bertani, everyone, and especially Manoli. I would like to remind everyone to please send questions in Portuguese or English at the end, or to be answered at the end. So please share with us in the chat, okay? The format will be a brief presentation by all three physicians. And after that, we'll discuss a little bit about and talk about the questions. And at the end, we'll try to answer any other questions that you guys may have, all right? Let's start today with Dr. Raphael talking a little bit about the Icp waveform.
Good evening, everyone. It's an honor to be here tonight with all of you. So before we get started, I will be giving a brief introduction to the Icp waveform and to what exactly we're looking at. What exactly is this device looking at? So, I have no conflicts of interest. So, to begin with, we have been monitoring intracranial pressure, which is ICP, for quite some time through catheters that go in the brain or inside the ventricles. And we mostly look at the number that they give us, which is the value for ICP, but we often overlook this information here, which is the actual ICP waveform. And what does this waveform mean? So when we look deeper into this waveform, we're actually looking inside the brain's actual physiology. And we see it's made up of three waves with three peaks: peak 1, peak 2, P3, or P1, 2, 3. So P1 is the reflex of the arterial pulse. So the heart is beating and the arterial arteries are pushing blood inside the brain, and this creates a pulse. This is the highest peak in the normal brain, P1, followed by a tidal wave, a tidal peak, which is the reflex of what just happened of this arterial pulse. And P3 is more related to the closing of the aortic valve, which is one of the heart's valve. So this is very intimately related to the heart cycle. So normally we have, as you can see here, P1 is way bigger than P2. And if we calculate a P2 over P1 radio, P2, P1 radio, we have it normally optimally under 0.8, which means P1 is very much bigger than P2. And what happens when we have something going on, maybe let's say hydrocephalus, excess fluid in the brain, we have an inversion of these peaks. So P2 is now bigger than P1, and the radio is now over the value of 0.8. And to understand this better, this is just a very quick graph which shows the intracranial volume, so the volume inside the skull, and the pressure inside the skull. As the volume keeps increasing, so does the pressure, and the brain will little by little lose its compliance. And what shows the brain's compliance, which is the ability of the brain to adapt to a larger volume that should not be there, to an actual volume, to increase in volume without changing the pressure inside it to a level that's unacceptable, to a level that causes injury, is the brain's compliance. And P2 is related to this compliance since it's the tidal wave, since it's the reflex of the arterial pulse inside the brain. So we have a brain with normal intracranial volume, normal pressure, intracranial pressure, and we see that P2, as we said before, is bigger, that P1 is bigger than P2, that's bigger than P3. So this is a normal waveform. The ratio here is under 0.8, and as the volume increases and the pressure increases, we have a lowering compliance, decreasing compliance of the brain, and P2 gets bigger than P1, and the ratio inverts to above 0.8 until there's no compliance, and ICP will spark. So this inversion of the waves, this inversion of ratio, is a sign that something is going on, compliance is decreasing, and therefore intracranial pressure is about to increase in consequence. And this information is all coming from this small portable device, and of course, non-invasive. We will be getting into more detail over the next presentation tonight during the event.
All right, thank you, Raphael. I would like, again, just to remind you guys to send questions, okay? Now I'd like to invite Dr. Giselle to talk to us a little bit about hydrocephalus and what she has been experiencing over here in Brazil. Doutora Giselle, you're on mute. So, yes, thank you. No, you continue on mute.
Sorry, now it's possible?
Now we're good, yes.
Okay, sorry for that. First of all, I would like to thank you the invitation to be here. And let's talk about hydrocephalus. What is hydrocephalus? Hydro means water, and cephalo is Greek, is head for in Greek. And the hydrocephalus is the buildup of fluid in the cavities, deep in the brain. The cavities named ventricles. And the excess fluid increases the size of the ventricles, and then typically causes increased pressure inside the skull. And we have it can happen at any age more frequent, but it is more frequently among infants and adults 60s and over. The older people can present headaches, double vision, poor balance, urinary incontinence, personality change, or mental impairments. In babies, we can have the rapid increase in head size. This is important signal. And other symptoms can be present: vomiting, sleepiness, seizures, and downward pointing of the eyes. Here we can see the video that can represent the hydrocephalus. We can see the enlargement of the ventricles, the cavities within the brain, and we can see the increasing of the brain pressure. The causes for the hydrocephalus, three main causes. The obstruction, partial obstruction of the normal flow of the cerebrospinal fluid, or poor absorption. Another problem with the mechanism that enable the blood vessels to absorb cerebrospinal fluid. And for example, causes for that: brain tissues, inflammation, infection, or injury, or even overproduction. And cerebrospinal fluid is created more quickly than it can be absorbed. For example, in brain tumors like carcinomas or papillomas of choroid plexus, it can be cause. And the possibilities of treatment for hydrocephalus, the most important are two. And the shunt, we can see the drain, excess cerebrospinal fluid from ventricles in the brain to the abdomen of the patient. And another technique is the endoscopic third ventriculostomy, that with this technique, the surgical technique, it's possible to create a bypass for the cerebrospinal fluid in the head. And these kinds of treatment are important to reduce the intracranial pressure caused for hydrocephalus. Thank you very much.
Thank you, Dr. Giselle. I would like now to invite Dr. Nelci to talk a bit about hydrocephalus in children. She will definitely show some experience that she has here with a few of our kids. I would like to say thank you to Maya too and her mom here. So, Dr. Nelci, please.
Thank you. Good night. It's a pleasure to be here. Share a little bit our experience. I don't know if my screen is sharing with you or not. You are seeing my screen?
Yes, ma'am.
Okay, thank you very much. First of all, I introduce myself. I am at the moment chair of the Pediatric Neurosurgical Committee of the World Federation. Also, the Women Committee in the Brazilian Society of Pediatric Neurosurgery. And
excuse me, Dr. Nelci. Dr. Nelci, I'm sorry. We see your screen, but the presentation is not on the screen. Just.
No. Oh, wow.
Yeah.
How I can explain this? Tell me. I can try maybe stop presentation and try to go again.
Yes, thank you.
We may try. We never know. Should work usually. But I can tell you, in this morning, it was a presentation from Chicago and very, very experienced neurosurgeon. I will try to, the old telling data, maybe?
Yes, please.
It was at the beginning one.
Yes, telling data will be great.
Okay, maybe. Should work. And on this morning, it was very difficult. It was Zoom presentation, but even with Zoom, probably connection. We are okay now?
Yes, thank you. We can see it now.
Okay, no conflict of interest. I just use a waveform just to improve the care of my patients. I'm working in São Paulo, and is an immigrant city, and this in the left side is a monument to the immigrants from Becheré. It's the Italo-Brazilian artist. Pediatric neurosurgery usually work in a team, and I'm working private and public also. We saw by Giselle and Raphael that if we have intracranial hypertension is or CSF or liquid or brain or blood, the compartments that have some troubles on it. And the physiological change of our intracranial pressure we have during the day several times, but is just a moment when we are doing some effort, we have some sports activity, we change our posture. But the question is when this changement became pathological. And to know the intracranial pressure, usually we need equipment that show us some numbers. But to know these numbers, we need to go to the operating room, and we have a cost. We need anesthesiology, is a neurosurgical procedure. We need intensive care unit, and it is not available all the time when we need. And time to time in the operating room, we need also neuronavigation. Is even more difficult to afford when we need. And another limitation in ICP monitoring for the children, we don't have a clear number of ICP for each age. We have some basis, but it's not perfect guidelines to be sure that our children is really normal or abnormal number. And now when we have some patients in outpatient clinic or at home or in the emergency room, not in the operating room, have symptoms, how we can deal with, how we know if there is something wrong inside. We need MRI, we need CT scan, and time to time we are working in the place where this equipment is not available for everyone. And just to have an idea, the World Federation and the WHO, the publication shows that headache is the third more common symptom in the neurological clinic. Just to have an idea how many people we can help with this equipment. When we have headache, when this headache is a sign that we have really intracranial hypertension, is our goal, try to show in an easy way, a non-invasive way, to show when there is something wrong with the children or the adults. Professor Sergio Mascarenhas have an excellent idea. I'm thanks for this brilliant work and ideas. Why the neurosurgeons need to go inside the skull to discover the brain waves or the intracranial pressure monitoring? We couldn't believe that it was possible to see just outside the skull, but it's not only a physicist, is a genius for me. He just got an idea, go in the lab, do the work in vitro, do in animal, and now we are with this, or in our mobile or in our computer, we can see the waves here. Is the normal waves like we see in decrease P1, P2, and P3, and non-invasive, just seeing. We can ask, well, yes, Nelci, you are telling me that we are seeing the waves, but these waves are really the same that we have where we are in intracranial pressure case or ICP monitoring invasive. In this small video, we see in this wave, we have the surgery, ICP monitoring, we have the number 21, 22, and here we have the non-invasive wave. You can see it's very, very similar in both of the case. If we can see without surgery and without invasive, is a very, very good solution for several cases. When we go to the clinical practice, we see, for example, a small baby, we just try to monitor him, but he has some movements, is a limitation for us. We can be sure that our monitoring is perfect. But when we have a child without movement, we can, like in this, is a small child, but it's possible to monitor her. Our limitation is when we have head circumference at least 47 centimeters. Below this range, we need to think in another solution. Another case, it's craniofacial syndromic case, not operating. We are monitoring. Is Gustavo, our researcher that help us when we have some doubts. And here we maybe have some difficulties to interpret online. It's not so easy that we see before. It's not a problem at the moment because these waves go to the cloud, and the analytic system do some clearance on these waves and send to us a very, very clear image. This, it was at the beginning without numbers, only the curve. In the left side, it was normal, P1, bigger than P2. And in the right side, P1, it was smaller than P2. The right side is pathological case. Is just to exemplify, is normal and abnormal. And between them, we have some doubts, no problem. We have another monitoring the next day or the next 2 days or the next week. Just one case, our children, 6 years old, not clear evidence of intracranial pressure, 6 neurosurgical procedures before, and the VP shunt with external regulation. This is MRI before shunt, and this one, right side, the MRI after shunt. Just to have an idea, the neurosurgical procedure done on this child, it was ventricular lavage and endoscopic third ventriculostomy. It means neuroendoscopy procedures, before VP shunt, and after VP shunt, 2 shunt revision, adjustment of the valve several times, but still with headache. And at the beginning, she was premature and intraventricular hemorrhage grade 3. And one revision, after the shunt revision, she became squint. And it was difficult times for her family. In 1 year, she got in the emergency room several times, and she got 10 lumbar puncture. When this child was monitoring, we can see here in the number 1, just a normal, it was no symptoms, before symptoms. The P1 bigger than P2. The symptoms came, and we just move to a pathological waves. And when the symptoms go out, the wave came back in not normal, but became better than it was with P1 bigger than P2. And when this came to us, we just do a shunt revision again, and she improved now for more than a year time. And now we have the numbers. When she was during the pathological states, the ratio P2 and P1, it was 2.8. After the headache, the P2 came better, but abnormal. It doesn't arrive in 0.8. We need several days to arrive there in some cases. Just a second case is a simple one, just to show the opposite. This child came, young adolescent, came with myelomeningocele VP shunt malfunction, and he was sent to us just for a shunt revision. And we decide the monitoring, it was a non-invasive pathological one, and we decide open the adjustment of the valve, and we can see here the improvement each day. And at the end of this case, we stopped the surgery and we canceled the surgery, and the patient stay well for a while. In summary, yes, we have a new tool. And em português, para alguns que estão nos ouvindo e não têm o inglês perfeito, nós combinamos de fazer um resumo, então. O monitor da pressão intracraniana exige cirurgia, equipamentos, UTI, um custo altíssimo. O monitoramento não invasivo, ele pode ser feito no consultório, o profissional pode mandar o enfermeiro, o fisioterapeuta ou o biomédico monitorizar em casa, e nós consideramos como um novo sinal vital. Agora está muito em moda medir a temperatura, na neuro, o martelinho é muito comum no exame neurológico, e o nosso sonho de consumo é que 4 milhões de pessoas se beneficiem dessas ondas cerebrais quando todos os neuros tiverem, os clínicos e os médicos tiverem à disposição esse dispositivo, que todo doente neurológico pode fazer um exame não invasivo antes da gente ir para tomografia ou ressonância ou transferência desse paciente para um lugar melhor. And my gratitude to Maya and for his family to trust our confidence in our work, and gratitude also to Brain Care for permit us to take care for these children without any cost for the patients and for us. And my mentor, Professor Maurice Schutz, and also Sergio Mascarenhas, our genius on this system. And for our team that stay when we are doing our work, they stay working for us. Thank you very much.
Thank you, Dr. Nelci. That was very, very good. And I think everyone now knows a lot more about non-invasive ICP monitoring, right? So, Raphael, now you have a hard job to do, is, to shine a little bit more than Dr. Nelci. So, ask you to please give your presentation about adult hydrocephalus.
Okay, thank you, Dr. Nelci, Dr. Giselle, for the beautiful presentations. So let us wrap things up and look a little bit into what about adult hydrocephalus? How do we use the device? So, well, in the first place, it's very common for us to look at hydrocephalus as a kid's thing, a children's problem, which is not entirely true. It's very important for the pediatric population, for sure, but it's also among adults. In the first place, because the same children that had hydrocephalus years ago now have their working shunts or had their endoscopic surgeries done and they are treated now, but they still have hydrocephalus, they can still have a shunt deflection, they can still need another procedure. And this is the congenital form of hydrocephalus, but it can also be acquired after trauma, after brain hemorrhage, after infection. Just like Dr. Giselle said, these events can impair the capacity of the brain on the arachnoid granulations to absorb the CSF back into the venous system, and this will end up accumulating. We can also have a more rare sort of congenital hydrocephalus that will appear later in life. So maybe, for example, a kid that has an accidental stenosis, but this only will develop symptoms later. It's not usual, but I've seen it happen, and it was quite surprising for the family, so it's something important to highlight the existence of. And lastly, we also have the normal pressure. We call it, I put it like this, normal pressure, because we were, in the beginning, we thought it was a normal pressure hydrocephalus, because these patients were commonly subject to lumbar taps, and we would see normal manometry, normal pressure. And later we found out, after we have continuous lumbar drainage, we found out that they actually have spikes of hypertension. So it's not absolutely normal pressure hydrocephalus. It's very much more common in older patients. And it's considered a chronic disease, which diagnosis may be challenging. Symptoms may not always be very specific, be very clear. So this may have some confusion. If you're looking at a patient with Parkinson, you may think about normal pressure hydrocephalus. Also in PH, if you have a patient with Alzheimer's, with other forms of dementia. So this is maybe challenging on the clinic. The physical examination may not be entirely clarifying, and imaging may be ambiguous as well. So it may be a problem to diagnose and treat these patients. Eventually, you will get the diagnosis, but this may take more time than we would like to. And this is, it's good to remember, this is the reason why the device was developed. This is where it all began. So these are the main forms of adult hydrocephalus. And it's also something we need to be aware of and treat, not only for the children that already had it and are now for patients as adults, but also for the others that may develop it for some other reason. And I brought to all of you a case in which we use the device. So we had this 57-year-old patient diagnosed and treated for MPH 3 years before, and he had an adjustable shunt. He returned to the hospital. He's drowsy. He has been complaining of headaches. He's very debilitated. The first clinician that saw him initially requested his head CT scan. It did show mild ventricular enlargement, but we already knew he had NPH, so it didn't give us very helpful insight. The catheter was in place, so it was inside the brain, it seemed to be working. The reservoir flushing test was normal. There didn't seem to be any abnormalities on that. And we see this waveform. We see P2 is clearly bigger than P1, and we have a 1.7, 1.5 ratio, which we consider to be pathological. I'm sorry for this to be in Portuguese. It's just the software is Portuguese, so there's not much we can do. But still, we look at this waveform. And since we have all these non-specific findings, first thing we try to do is we try to adjust his shunt since it's adjustable, and we see all the pressure is in 10. Let's put it down to 6 with less pressure. It will be draining more CSF. And we have also, as soon as we did this, we looked at the waveform and we see mild improvement. It's still not looking anywhere close to normal. And then a new CT scan. In the future, maybe this won't even be necessary since we already know after a few hours since adjustment that it's not changing. The patient was still symptomatic the following day. And we did a new CT scan and we could see that it seemed that the catheter was not very well positioned in the patient's peritoneum. So it could be obstructed. We were not entirely sure, but we had a not so normal CT scan of the abdominal pelvis together with this abnormal waveform. So we decided to reoperate this patient. And when we opened the abdominal incision, we saw that the shunt was not really well positioned. We had a lot of CSF coming out in high pressure. And right after the following day, we of course put the shunt back in place. And the following day, we replaced the shunt, put it in the regular normal position. And the following day, we have better compliance already. We have a better waveform already. And the patient is laying down. He's better from the symptoms, but not entirely good. So we wait another day, and then the next day, on the same laying down position, he is now presenting good recovery. His waveform is heading towards being more normal. We already know he has NPH, so we do not expect him to be perfectly normal, but we're very satisfied with the results, and we let him go. And he comes back a week later, and we see a much more physiological looking, much more normal waveform. And this was a sitting down position, which is much more physiological. It's more natural for us to be standing up and sitting down. But the reason why we did this laying down is because he was still having trouble. When he got to us, he was still having trouble with getting up. So we required him to be laying down for the exam to be, as Nelci said, perfect. We had him in quiet laying down, and we were able to do this. And when he came back, he was already so much better that he could already sit down, and we could do the full exam with him sitting down or full monitoring, and it showed absolutely normal values. And how did we get to this? How did we learn how to use the device? So how do we train ourselves, not only with the help of the excellent team from Brain4Care, but we also did ourselves a small study. We had 14 patients with adult onset hydrocephalus that were not operated, and 2 of them that already had shunts but were adjustable shunts. All of them required either to be operated to receive a shunt or to have shunts adjusted. They were monitored before and after the procedures, either surgery or adjusting, and all of them had a pathological P2-P1 ratio. All of them were above 1.2. After the surgery, after the adjustment, 14 of these patients improved. The P2-P1 ratio went below 1.0, and now, okay, why 1.0? Why not 8? Well, because not all of them end up going back to a normal ratio because they do have hydrocephalus. So we are a little bit more tolerant with these patients, knowing that, especially immediately post-procedure, knowing that they will probably tend to have a more abnormal compliance. From 2 of the patients from the surgical group did not go back to a smaller than 1.0 ratio, but they did go from 1.5 to 1.2, which is already a significant improvement, and they all improved from the symptoms, which is, of course, very important for us. All of them were in the laying down position because we wanted to do something that was the same for everyone. So these patients, when they got to us, most of them could not get up. They were in very precautious, very difficult situation. They were very symptomatic. So all of them are laying down, so we did everything laying down, so we have the same baseline. And this is important to mention because, as Dr. Nelci was saying, this will vary if the patient is standing up. We consider the normal waveform with the patient in supine position, so when we lay down, we may have this alteration, especially in patients with hydrocephalus and other neurological issues. This is just an example. We show the P2-P1 ratio of one of the patients before surgery, and right after, we can see the difference in the waveform with a very high P2 peak, and then reverting to normal with a higher P1, and then following by P2 and P3, and a much more normal looking ratio. So our conclusions is it's really a very safe method without complications of invasive procedures. Although we're not looking directly into ICP, we're looking at the waveform, which does give us very valuable insight without needing to perform an invasive procedures. And it was able to show waveform in basically all of our patients that we already knew, we already suspected that they had low compliance or intracranial hypertension. We already knew the diagnosis, so this matched perfectly with what we expected from them. It's simple to use, but we do need to be trained for it. We do need help from the B4C, Brain for Care team, which is always very helpful, thankfully, to implement this device in our centers. And this is a very important part because the team needs to work very well for these results to be meaningful and significant. And the way I see it, the way we have seen it, it's another tool for us alongside imaging, alongside clinical examination, and everything else. So I think we're taking a right turn here towards the future, which is always very exciting to us. I would just want to let a big thank you from my team. This is my references, and thank you all of you. We will now be available to answer any questions you may have.
All right. Thank you, Raphael. This is a great, great presentation. Well, Dr. Nelci, I have a couple of questions here. Maybe I'll start with Dr. Nelci, but you guys can discuss a little bit about, and I'll go through it in all these questions, okay? The question that I have is about the mechanisms by which the sensor captures the waveform. And what is P2-P1 ratio? Does the sensor provide only the waveform? What is it that we are getting? So if anyone could give us a little bit of thought about that, that would be wonderful.
Okay, thank you for the question. We are learning too. We are just starting. We have a lot to learn together, and how many people can join us better we can understand. About the mechanism, just to tell you the story, before start the story, when Professor Sergio Mascarenhas got this idea, he with problems and talking with neurosurgeons about the subject. He came to my house and tried to give me the idea for me to try to help him to develop, and I couldn't understand the geniality of his idea. He tell me, Nelci, I'm sure that is possible. We don't need to open the skull to go in. The idea was he bring the sensor that the engineers use to building bridges, to building edificios, buildings. Thank you. Buildings and bridge. We saw this structure with things that are something rigid without any movement, but is not. There is one intelligence on this rigidity that permits don't fall down when we have a wind or something like that. It's the same sensor. He used at the beginning the same sensor. Is not other, is the same. With time, the other engineers came and just smaller this equipment and give other functions. But probably the next meeting, we need to bring some of the guys from the engineering to explain to us too. But the second question, when we start 2 years ago or 3 years ago with this waveform, it was only the waveform. I can tell you we trust the waveform because we compare with the symptoms, we compare with the MRI, we compare with a CT scan, and we became more and more comfortable with the waveform without any numbers. With time and the improvement of the system, now they can do by Wi-Fi without any other equipment. Now we have the numbers. It's already established that the normal P1, P2 ratio is, the normal is below 0.8. And if we have the number above, we see already the waveform is different, but we have the confirmation with the numbers. And this confirmation became after that we was already working. We already trust the waveform because in clinical practice, it was a new tool that give us confidence or doing surgery or not doing surgery. I'm not sure that I could answer the question, but if not, try to do the question again.
Okay.
I don't know
I think
if Giselle
pretty
Raphael
yeah.
can add something.
I think it's exactly as you were saying. We have a new tool, so we may not have the number of the ICP, but we have an idea of what's going on, what's about to happen as the waveform is changing and compliance is falling. As Dr. Nelci just mentioned, the device is able to measure micro deformations on the skull. So this it's not enough to give us a number on ICP, but it's enough to show us what's happening inside and how the waveform looks like. And it's, as she also said, it's something that we're still learning how to use. We're still training ourselves and others to use this new tool. And with time, we will continue to develop new applications and new ways of using it and new insights that we can acquire from it.
Great, great. And just to add a little bit more, right? We use it as an additional information, right, Dr. Nelci? We're not using it as a diagnostic information. So just to make it clear to everyone, is an additional information so you guys can decide what best to do, right? Dr. Giselle, would you like to tell us a little bit? I have another question about, is non-invasive methods the future of medicine?
Absolutely. I fully agree with you. I think this is important too, and to decide the best treatment for the patient. We have observed excellent results in many pathologies, since from craniosynostosis cases to hydrocephalus. This tool is really interesting to see. This changes the ICP changes. Then I really believe that the future will be the new tool. This new tool will have an important place in these cases and to define the best option of treatment.
Nice. Dr. Raphael, do you think that this method is a substitute to invasive ICP? This is another question that we received.
We have different uses for different methods. I would say, as we've been saying right now, it's an extra to it's something else. It does not give us the same insight as the number of the ICP. It's something completely different, and it has the upside of being non-invasive. So I wouldn't say, not in the present, not right now, that it's a substitute for anything. But it's something new that we're all learning how to use, and we will see what the future holds for us with this new insight, this new information.
May I add something?
Of course.
Like Franco Servadei, the president of the World Federation, talk every time when he talk about neurotrauma. He showed us in Beijing during the last meeting that 80% of the papers to treat neurotrauma came for above the equator. When we have economical situation in high-income countries. But the problem is 80% of the patients are below the equator line. And below the equator line, the majority of the patients are not affordable to have ICP monitoring. Is the reason is so difficult to do. For example, why Brazil have this wonderful tool and it was impossible to do this clinical trial comparing intracranial pressure monitoring and non-invasive monitoring. We need the help of the colleagues from the United States for adults and children. Why? Why we have two kinds of medicine too. We have private and public medicine in Brazil. In private medicine, we can use intracranial pressure monitoring, but we're going the patient with neurotrauma. They go into public hospital, and public hospital is not always affordable to have. And this non-invasive can save lives.
Yeah. Dr. Giselle, would you like to add anything?
Yeah, I agree with Dr. Nelci. I think there are different methods and different realities. And the non-invasive method will be an innovative tool, and it can help, especially in developing countries, especially. I think it will have a great application.
Good, very good. All right, this is a good question that we have here. Do you see a change in waveform when the ICP gets too low, negative pressure? Anyone who wants to answer that one? This is a tough one.
Negative pressure is very, very difficult to treat. We have, I'm not sure that the last patient we have during our monitoring was with low pressure, intracranial pressure. By clinical sign, we have the same symptoms, but when we have intracranial pressure monitoring, ICP monitoring, we see the lower number. We need to prove with future and time what the waveform can bring to us. We don't have the expertise and this answer until now. Why? Because it's very rare to have, very difficult to catch. But when we have this information, yes, the great answer is, just to tell you one of my last case that it was with intracranial ICP monitoring. The engineer for the international company just called me, Nelci, I will bring you another ICP monitor without cost, because this have a problem, is -10, -15, -20, probably is wrong. And I was in the hospital, just do Valsalva maneuver, and it was normal. And this is difficult to manage. But if we can catch at the beginning, we need to compare intracranial pressure invasive monitoring and non-invasive monitoring to have learning curve for the future to be comfortable to deal with only non-invasive. But at the moment, it's necessary to work with both invasive and non-invasive to help the patient.
Great. Dr. Nelci, just an addendum here. This method now, just to make it clear, right, we're talking about the brain intracranial compliance, right? Not necessarily about the absolute value of the ICP itself, correct?
Yes, and it's just a feeling. It's not proven at the moment. We are just starting. For my thoughts, for my belief, and for my very, very small experience, we are just starting. The brain complacency, I don't know, compliancy in English, means different wave when we translate to Portuguese. Complacência is very different than compliance in English, but probably it will be the same word. I think will be more important work with compliance. Why? Because in some cases, we just bring normal ICP and abnormal complacency. And just hours afterwards, the ICP monitoring came and gave us the answer. And if we are right, we need maybe have 100 of patients to guess these, or to be sure that will be like that. But my feeling for this small amount of patients that we are taking care now is that the complacency is better and precocious sign that intracranial pressure.
All right, very good. Anyone wants to add anything?
I think it's exactly what you all of you have been saying. We are not looking at the number. Okay? We're not looking at the ICP. We're looking at the waveform. We may have a patient with a slightly elevated ICP, but he still may be compensated. He still may have a normal or almost normal compliance, and we may see a normal or almost normal waveform. So for these cases, as well as patients with negative ICP or low ICP, we may have normal waveforms. But honestly, I've never monitored a patient with negative ICP. That would be very interesting. I would love to. But it's, again, it's something that the future will tell us.
All right. We'll have the last question here, and then you guys will have opportunity to make your closing arguments and everything, okay? So how can a waveform impact, or even better, patients' quality of life? Anyone have seen that before? I bet all of you have.
Just to have an idea, the quality of life can be applied in several different ways. Quality of life depends on what means for you, bio, psycho, and social feelings. But when you are sick, you have hydrocephalus or you have some pathologies, the quality of life means, for example, Maya came to the hospital 10, 12 times, and we couldn't catch up because when she arrived in the hospital, she feel better in few hours and few moments, and we sent her at home. Why? Because it was normal ophthalmological examination, normal MRI, normal vital sinus, and she came back again and again and again. We couldn't do the diagnosis from this girl in the hospital. What was the trick to bring quality of life for this special girl? The mom tell us it was at night at home. When we arrive in the hospital, normally we don't have this manifestation in the hospital. Usually we call psychologists to see what is going on. But we send a nurse at home for this mom, and we monitoring Maya before the headache. We monitoring during the headache. We monitoring after the headache. And we it was possible to see that it was real. The waveform was normal before the headache, became abnormal during the headache, became better but not normal after the headache. It was very, very important for us to take the decision to operate again. And probably to have a better quality of life, we need to see the cause for what's going on to have this trouble in quality of life. Probably it's a tool, additional tool. It's not a salvation for all the problems. But when we have a problem that we can't find the solution, is a new possibility, is another possibility, another tool. I'm quite optimistic. Then we can help a lot of children, a lot of adults too, not only in neurology. One of the recent work, it was in ICU unit after cardiac surgery. They doesn't knew before that there is a lot of changements in brain wave after cardiac surgery. And usually we don't put inside the brain ICP monitoring to help them. And we are improving the quality of life for these patients doing a non-invasive way.
Awesome. Very good. Anyone else would like to add anything? Or
I think especially in cases like hydrocephalus with a programmable valve, we can define the right pressure for this child. I had recently a case, then I could define the best pressure for the valve for child after the ICP non-invasive model. And then it's really important for child, for quality of life. And she became asymptomatic after this monitoring. Then I think it's so important.
great. So Dr. Giselle, you were able to adjust her shunt or her valve with the waveform. So you kept looking at the waveform and were able to say, here, this is the good pressure. I'm satisfied with that. And perhaps she won't have any more pain or headaches or anything.
Exactly.
Great.
Exactly.
Definitely quality of life. Raphael, anything or?
Yes, I think we are always trying to spare our patients from whatever type of suffering. Maybe someday we'll be able to spare them from a lumbar tap, from a CT scan that's radiation that may be difficult for them to go through, or maybe sparing them from coming again and again and again to our clinic because of a valve adjustment that maybe can be more simple in the future. Or even maybe we're giving them a better experience that instead of sticking a needle in their backs, they may be sitting with us for 5 minutes while we do the monitoring. And maybe that's enough for us. Maybe they will still need the puncture, maybe they will still need the CT scan in the present right now, but maybe soon we will not be needing so many invasive procedures, so many scans, so many visits to ourselves. Maybe we can make it better experience for them. I think there was one last question about if there's any effects on the waveform monitoring if the patient has a craniotomy previously or a cranioplasty or a fracture. I would say I don't have enough experience with monitoring patients with cranioplasties, especially from different materials. We did it sometimes, but we have always been placing the device on an area of the skull that has nothing. So if the craniotomy is here, we just place the device here, and so on. So I would say maybe it does change something, but most of the times you will be able to avoid the altered area and place the device, the sensor somewhere. It's normal.
Awesome. Great. I have a question myself. Do you guys believe that you can see a change in the ICP pulse morphology before you can see a change in the absolute value of the number in itself, in the pressure in itself? Or perhaps morphological changes? I don't know. I was just thinking, do you think that what changes before first is the morphology, or, trying to see if we can detect stuff earlier, perhaps in time? So being a little bit faster, it gives you information a little bit faster than, waiting to see on a clinics or perhaps in another available monitoring or monitorization exam that you might do. Just wondering.
Is a feeling. We can catch the waveform alteration before, for example, fundoscopy to have papilledema. This is already seen in the patients. There are other trials going on now to see if there is comparison with other non-invasive monitoring, like MRI on the optic nerve or ultrasound in the optic nerve. Soon, probably in 6 months' time, we will have probably 10 or more papers on this field and more knowledge on the stage to discuss the real situation.
Anyone else? All right.
I think if someone has more questions, they can contact us directly. For the time being, we have, if I can, we can maybe for 1 second just put back our email, so if anyone has anything, we can.
Yes.
We can.
So. Okay.
Okay. There it is. So
all right.
maybe all of us can do this for 1 second. So they're just that if we have any further questions, they can be answered.
Let's put in the comments. I'll put Gabi, if you could put their contact information in the comments, so perhaps anyone that may have any questions, they can contact them directly. We are more than glad to answer any other questions. Right now, we'll have a couple minutes for each of you just to do your closing statements. Let's start with Dr. Giselle, perhaps.
Thank you very much for this opportunity. It was a great time to discuss these things and these findings of this new technology. I fully believe that it will be the future for sure.
Dr. Raphael?
I think it's we have new technology coming up in every single area, and it's up to us to adapt to it, learn how to use it, and try to make the best of it for ourselves and for our patients. So it was a great experience to be with all of you here today, the Brain for Care team, and these two excellent, great, inspiring neurosurgeons. Very, very pleasant to be here tonight.
Dr. Nelci, please.
Thank you very much. It's great. We know that in science and medicine, we need time. But like a physician, a doctor, is our duty to try to improve the quality of life for our patients. And if we have this opportunity, we can bring and go and do our best for try to improve and to give their life better than now. It's our duty. Thank you very much.
True.
Great. I would like to say thank you to everyone that stayed up to now with us. And also thank you to Manoli to provide us with this space. And of course, I must say thank you to all three of you. It was wonderful. It was a great time and experience for me individually. You know, I learned a lot in this last hour. And hopefully we can find many physicians like all three of you and maybe perhaps change the world and provide more healthcare, better healthcare to those who are in need. Thank you so much, you guys. Have a wonderful night.
Bye-bye.
And ciao.
Bye.